for your discussion on the age to start. The next question is, at what interval should we screen? And this will be discussed by an American health economist and a European clinician. Shalini, may I invite you to give your viewpoint, please?
So I'm going to discuss the optimal screening intervals from a US perspective. I think the first thing to think about when we're talking about the US is that we have a fear of death, which is common to every country. But our fear of death is such that we are willing to spend a lot of money to address that fear, and maybe too much money, because we want that risk to be zero. And so when you look at our guidelines, it reflects that cultural perspective on death. And so this is prior to this year. These are our three main bodies: the United States Preventive Services Task Force, the American Cancer Society, and the American College of Obstetrics and Gynecology. And so the first thing to note is that for the US Preventive Services Task Force, they only recommended cytology. They did not recommend co-testing or any form of HPV-based testing prior to this year. And the recommendation was for screening to be conducted every 3 years from age 21 to 65. The American Cancer Society, for their cytology recommendations, they recommended every year if it was with a conventional PAP, or every 2 years with liquid cytology. They also had a recommendation for co-testing, and that was for that it be conducted every 3 years for women aged. This is just going by itself. Yeah, okay. It just be conducted every 3 years for women aged 30 years and older. ACOG had similar guidelines to the ACS for co-testing, but what you'll notice is for their cytology, they recommended screening every 2 years, and then it could be increased to every 3 years if women had a history of 3 negative cytology tests. Here are the new guidelines. And I think the thing that is most impressive about it is we are all now saying the same thing, all three bodies. So the task force has added co-testing, and now the ACS, ASCCP, ASCP, and ACOG have the same screening interval for cytology that the task force had. So what is it? There's no way to stop this, is there? Okay. It's screening every 3 years from age 21 to 65 with cytology. And if you're going to do co-testing, then that should be conducted every 5 years. So what is the basis for these recommendations? So first I'm going to focus on the interval for cytology only. And this is work that was done as part of a working group. And I'm just going to present the results for our working group, which was done for the ASCCP, ACS, and ASCP. And what we were tasked with was looking at the optimal screening interval for cytology. So there are trade-offs, as with anything. Basically, what we know is annual screening has been consistently shown, at least in modeling studies, to not be very cost-effective. Basically, you have small additional gains in life expectancy for a high number of additional procedures, especially when you compare it to screening every 2 or 3 years. And then epidemiologic studies show no significant difference in reductions in cancer incidence between screening conducted every 2 years compared to every 3 years. And generally, while there are benefits associated with frequent screening, which is a very low risk of cervical cancer, the harms include increased testing and potentially unnecessary procedures. So this is lifetime risk of cervical cancer, and as you would expect, it decreases with increasing interval. However, you pay a price for that. If we assume that colposcopies represent a metric of the burden associated with screening, then what you see is converse. So there's a greater burden associated with screening more frequently if you use colposcopies as your metric. So based on this, our group at least decided that when you weigh the pros and cons of screening and you compare every year, every 2 years, and every 3 years, screening every 3 years seems to provide the best balance, or the most optimal balance, of the burden and the benefits of screening. So the next question is, well, what should we do with women who have been screened, and if they, in particular, if they have a history of normal pap smears? And so what we wanted to do was look at the screening interval after normal cytology results. And as you can imagine, this is also associated with age. So in particular, we were interested in saying, can we change the screening interval for cytology if a woman has a history of prior normal pap smears and she's 30 years of age and older? So this is the evidence. Okay, let's go back. This is a study by Vicky et al. And what they did was they calculated a standardized incidence ratio, basically observed versus expected cancers, associated with a 5-year screening interval using data from Finland. What you would expect, and what they showed, was a reduced risk of cancer after a negative pap smear. But then what was important about this study is that after that initial negative test, you begin to see an increase in risk as a function of time. That increases all the way up to 5 years. This is a study by Miller et al. This is a case control study of 482 cases in a large managed care system in the US. They estimated the odds ratio for cancer associated with different intervals since the last normal cytology test result. And what they showed was that the odds ratio for cancer associated with screening every 3 years versus 2 years was not significantly different. But what they did find was a significantly increased odds ratio when the interval was increased from that last negative pap smear was increased beyond 3 years. The other interesting component of this was that controlling for previous consecutive negative cytology tests did not change their results. So, and finally, where are these people? Okay. So, finally, this is another study by Graham et al., where they estimated the rate of subsequent cancer in 41,000 women undergoing opportunistic screening in Norway who had a negative cytology result. They did not find a significantly reduced risk of cancer or sin associated with increasing number of prior negative cytology tests after they took into account time since last normal cytology test. What does this mean in English? Well, what this means is that the most important thing after your normal test result is the time. And how long has it been since that time? That's more important, these studies are saying, that's more important than how many prior normal tests you've had. So based on this then, the screening interval for cytology, we concluded there's a high burden of procedures associated with annual screening, no significant difference in cancer risk between screening every 2 and 3 years. There's a significantly increased risk of cancer when the interval starts being increased beyond 3 years, and that your time since your last normal cytology test is predictive of this increased risk of cancer, but your prior number of normal cytology test results is not once you've accounted for time. So the bottom line, screen women with cytology, but do this regardless of age and prior number of normal cytology test results, screen them every 3 years. So that was our conclusion. Okay, well, what about co-testing? Well, I think this graph summarizes all. This is by Kotke et al. And in figure A, what you see is if you screen with HPV and PAP separately. And the third line down, the dotted line, is this the? Shows you the risk associated with cytology only. And then in figure B, what you see is a much lower risk, 5 years out, for co-testing if you're negative on both. Hence the rationale for screening less frequently in this group. These results have been confirmed by a study conducted by Dr. Dillner and colleagues, where they pooled data from European countries, and they showed a similar magnitude of subsequent risk of SIN3 as that reported by Kotke et al. For dual negative test results and a negative cytology result. Dr. Kotke and his colleagues have updated those findings, and there's a poster that's being presented, CP 325. And again, they confirm this very low risk associated with dual negative results compared to a negative cytology test result. And then in a report we had done for the task force that my colleagues and I did using modeling, it suggests that under certain conditions, co-testing conducted every 5 years may be associated with fewer colposcopies per life year gained than cytology conducted every 3 years. And so based on this body of evidence, the recommendation is for screening with a 5-year interval for co-testing. So in summary, the US cervical cancer screening recommendations are now consistent between the 3 groups: the US Preventive Services Task Force, ACS, ASCCP, ASCP, and ACOG. And those guidelines are simple and straightforward. Screen every 3 years with cytology, and screen every 5 years with HPV and cytology for women 30 years and older. And I think in terms of the US compared to the European perspective, the most important thing now is that the Europeans can't call us crazy and can't laugh at us anymore. Thank you.
Thank you, Shalini. I invite now Mario Sideri to present his European viewpoint. Mario Sideri is a gynecologist from Milan, an expert in colposcopy, and involved in guidelines development.
Okay, good morning. I thank the organizer to give him this presentation. I'm a gynecologist, I'm not an epidemiologist, so I am not in my field. As you know, in Europe, most of the countries have organized screening program in place. I will try to keep the perspective of a public health system. Just to remember the Nobel Prize for 2000, to discover the linkage between HPV and cancer. And what is the Nobel Prize means that with no HPV, there is no cancer. And in the natural history of the development of cancer, we had some new data from the normal cervix that is infected. There is a transit infection, persistent infection can lead to a precancer and then cancer. So detection and intervention, precancer examination is the old strategy. And the new natural history opens some new possibility, prevention of infection, that is vaccination, and identification of at-risk population with the HPV testing. And in fact, in the natural history, we now add a new step that comes earlier than what we did with the pap smear. So, fortunately, I live in Italy, and in Italy there is an organized screening program, and also lives a group of researchers led by Dr. Roncon. They did the study. And I would like to present some of the data of the study. The study was put in the frame of the organized screening program and randomized 100,000 women to conventional cytology and HPV testing every 3 years, and 2 screening rounds were completed. And the primary endpoint was the detection of CIN2-3 and cervical cancer at first and second screen, and always the analysis was done the intention to screen. So the results at the first round showed that in the HPV arm, you detected twice the number of CIN2-3 than pap smear screening. What is the question is this new CIN3 clinically relevant? And so go to the second round, and in the second round, in the HPV group, there was half of the CIN3 identified in the pap smear group. What does this mean? This means that you anticipated the diagnosis of CIN2-3, and which is the clinical value of this anticipation in diagnosis. That is the step to increase the intervals between 2 screens. And this is logical because we are detecting a step that comes before the precancer formation. And so, as in the natural history we are before, we can elongate the interval. But what happens to invasive cancer? In the first round, there was the same in the HPV group and the pap smear group, but in the second round, there were no cancer in the HPV group, while 7 cancer, the same number of cancer in the pap smear group. So, what is the meaning? is if you live in a population and untreated CN23, this carries the risk of cancer development, and this is something that we know for time. So the clinical consequence of the study was to stop the pap smear screening at 3 years interval and switch to HPV testing at longer interval, because you can detect before, and then you have your population that can stay longer time without seeing a physician, a nurse, or the medical system. And we know that in screening healthy patients, healthy women, this is very important. So the results of HPV testing is reassure more than 90% of negative women, an interval increase, and offer better protection against cancer. These results were confirmed at the European level by other studies, and also the second round results were confirmed where you anticipate the diagnosis. And Dillner demonstrated in an overview of several European core studies that the cumulative incidence of rate of CN3 after 6 years was considerably lower among women negative for HPV test at baseline compared with negative pap smear. And the cumulative incidence rate for women in negative cytology results at the most commonly recommended screening interval is in Europe is 0.5, while HPV testing is 0.3 at 6 years. And these are the figures and the protection that HPV testing can give to the population in comparison with the pap smear. So, no HPV, no cancer. We were good in giving the Nobel Prize to 2000. And HPV testing is at least twice as good as cytology in providing low risk period after testing negative, measured either by high-grade CIN rates, a specific time, or the period when either the test has the same overall high-grade CIN rate on follow-up. Prolonged intervals have two advantages. It is safer, reduced probability of undue colposcopy and treatment, and cost reduction. Less is better, and this is our knowledge, our scientific knowledge, allows us to do less and better. Screening with HPV testing at intervals of at least 5 years are currently recommendable when a 3-year interval is used with cytology. Further increase are possible when 5 years intervals is already used in Europe with cytology. And there is evidence for longer intervals could result from further follow-up studies or randomized control population and from implementation pilot projects. So what is common across the Atlantic Sea? Annual pap smear era is finished, and since I am a gynecologist, I know that many gynecologists in Europe or all over the world, they use the annual pap smear. And this is something that has been shown that HPV testing is better than the pap smear, and this makes a very deep change in the attitude of gynecologists, and we are ready to take this FIDE. Okay, thank you.